Thanks for joining us for our KSLA Cafe Conversations. I'm Adria Goins. Dominique is not here with us today, but we're going to continue to do a special Heart Healthy segment without her. You know, this is Heart Awareness Month, February. We just began February, and now it's a chance for you to make some decisions on checking to make sure that you are living a very heart-healthy life. So we have a special guest with us here today, Dr. Jonathan Davis from Piermont Cardiology. Thanks for being here.
Thank you for having me.
Now this is something that I take very seriously. Heart disease runs in my family. My dad has had a heart attack. My grandfather died from heart disease. So it's something that has affected my family, affects millions of others. But one question I wanted to ask you first is, why is it that women are more susceptible to heart disease?
Well, I think that this whole campaign, Go Red for Women, is a product of raising awareness. When you have awareness, then you can actually then work on preventive strategies. And it's not that women are affected more than men. The numbers are about the same, truthfully. It's just that women have been conditioned to think that they're at more risk for, say, things like breast cancer. Okay. Breast cancer awareness has made a big impact on women's awareness and prevention of breast cancer. And really, I think this whole Go Red for Women initiative is born out of that idea that if we raise awareness that women can have heart disease too, and it's not just a man's disease, that's when the preventive strategies can really impact how much it affects them.
What are some of the warning signs that women need to look for? Because oftentimes women overlook warning signs because they're stressed out from getting kids here and there and making dinner and this and that, and really don't focus on warning signs, would you say? Well, what are some of the warning signs they should be looking for?
I think any sudden change in anything you should ask yourself, is this something more? Everyone wants to discount whatever it is they're dealing with. Yeah. And women's symptoms can be different than men. They tend to present more with shortness of breath acutely, and not so much the classic, elephant in the chest that kind of has been made out to be the hallmark signs of a heart attack. So I think it's really just an awareness that something's different. I need to ask myself, is this something that needs to be followed up on? And admittedly, people are reluctant to go to health care. They don't know where to go. Do I go to an urgent care, an emergency room, my primary doctor's office? And again, it's just, could this be a heart attack, and what should I do, and what are my next steps? I think it doesn't matter who you are. You could be 80, 40, whatever, and you're asking yourself the same questions, because people come to the emergency room all the time. They can't believe that they're having a heart attack based on whatever the symptom might be.
Yeah, how often or how important is it for you to get to the hospital as quickly as you can when you're having an issue with your heart? Because a lot of times people say, oh, I'll just wait till tomorrow.
That's right.
It can do damage.
Absolutely. There's the sort of the motto or sort of campaign of time is muscle, time matters. And so, there's this golden hour of, if you present within an hour of your symptoms, then the likelihood that we can save a lot of the heart muscle if you are in fact having a heart attack, time is critical. And unfortunately too, sometimes time is critical. You could recognize your symptoms and fall dead from a heart attack and have sudden death as the initial manifestation of a heart attack.
Wow. That's scary. How do you know, though, the difference? How do you know the difference between this being an anxiety attack or a heart problem?
That is the dilemma for all of us. You're never certain. Certainly we meet people in the emergency room setting, and it's obvious what's going on. But a lot of times it's more subtle, and that's really what, first responders calling 911 if you really think you're. And then sometimes you have to go to the emergency room for the reassurance of what it's not. And it's more common that patients come and their evaluations are favorable for them, and it wasn't a heart attack, but it does bring them into the arena of healthcare providers that can then say, okay, this wasn't an event, but these are the things that are going to put you at risk to potentially have one in the future. Right. And let's start a conversation, a relationship to work towards reducing our risk.
And my thing is that if I have to go, burn a $50 copay just to reassure myself that I'm safe by going to see a doctor, urgent care, what have you, it's worth it. right? Because it's saving your life just to make sure you know exactly what's going on and that you're not at risk of a heart attack.
That's right. Well, again, I think it starts that relationship, and then we have so many avenues and modalities to evaluate people and try to really risk assess them. Everyone wants the money back guarantee, 100%, and that's just not a realistic expectation. You know, I tell people in my office all the time that when we're talking about heart disease, you can be fine 1 minute and having a problem 2 days, a month later, and that's if you have a stress test, a heart cath. So then there's two diseases we deal with. We deal with stable heart disease, and we deal with these unstable coronary syndromes, we call them, heart disease, heart attack kind of scenarios. And so really it's a relationship with a healthcare provider, and then ongoing evaluation and risk assessment. And you know, so much can be done, and unfortunately sometimes we only see patients when they're manifesting their disease the first time.
What are some preventative measures that people can take to make sure that they aren't at risk of heart disease?
Well, I think, you know, there's sort of this slogan of know your numbers. So, you know, you can't know your risk if you don't know your numbers. And so blood pressure, body weight, blood sugar, how many minutes a week do you exercise? You know, and so all of these things, because heart disease is really a manifestation of two things going on in parallel. One is usually time, and then two is how much time do these factors have to interact with each other to lead to heart disease. And so, you know, they've done studies, autopsy studies from Vietnam, where soldiers were killed in the line of duty and they were autopsied, and they had the precursors of what would have become plaque or blockage later in life had they not been killed in the line of service in their 20s. So really, you know, in some sick kind of way, we're incubators of disease. And so the incubation period starts, and then you start, when you get in your 60s, it's no wonder heart disease starts to really manifest itself later in life.
So is there a time frame then? Would you recommend start going to the doctor every 6 months to a year? I mean, would you say a 30-year-old do that because compared to a 50 or 60-year-old?
Absolutely, absolutely. I mean, we're seeing more and more young people with heart disease, and that's born out of two problems. Well, one major health problem in America, which is obesity and diabetes. And so that creates something that we refer to as metabolic syndrome, where patients have obesity, high blood pressure, and abnormal lipids. And if we're going to intervene in a preventive way, we need to be seeing those patients, you know, when they transition from, you know, teenagers into adults. And, you know, it's recommended to have a lipid panel. I mean, that's a simple blood test, and it's a simple assessment of blood sugar. You know, you can talk about whether people smoke or not, all these things. And so really, it sounds simple. It's nothing glamorous about it, but we can begin to identify risk. And again, it's that time frame. You know, and so we are seeing patients. You know, one of my partners, you know, took care of someone recently with a heart attack at age 31.
Oh my gosh. Wow. So this is where this whole heart disease plays a role in my family. It's something that's very important to me, that I think about often. My dad's brother died of a heart attack when he was in his 40s. My dad had a heart attack. His dad, my grandfather, died of one. So obviously there is a record of family history. In fact, I had a stress test through Willis-Knighton just last year because we were doing a story about how, you know, how heart disease affects your life. And, you know, I'm not gonna lie, I don't sleep very much because of this job. I get up early, I have young children at home, so I don't get much sleep. I do exercise, which is really good, but how important is it that I make sure I get more sleep and that I'm eating right and exercise, especially with someone like me who has a family history of heart disease?
I think you've hit the nail on the head. So lifestyle trumps everything else.
Okay.
Family history is important, and family history, You can't, it's the one of the non-modifiable risk factors. You can modify whether you smoke, you can modify whether you're obese or not. But family history is important. And family history, sometimes in my office, I have to remind my patients, it's first-degree relatives, and a premature family history of heart disease is if your dad had a heart attack or a vascular event before he's 55 and your mom before 65. Mm-hmm. And so, because sometimes people start talking about 2 generations, 3 generations removed, and that conversation as it applied to sort of modern healthcare, blood pressure agents weren't available, cholesterol medicines, but exercise and lifestyle can trump family history, in my opinion.
Okay.
And so I think that the other thing about families is that if families have bad behaviors, they have the same health outcomes. So a family that doesn't exercise, or a family of smokers, they can expect the same kind of health outcomes.
Okay.
And so really some of the social factors are as important or more important than necessarily who your mom and dad are, because you can really modify so much of it. 150 minutes a week of aerobic walking reduces risk by 50%.
Oh, wow. That's
so,
significant. And 150, you said 150 minutes?
Yep.
That's not much at all.
30 minutes, 5 days a week.
Yeah.
But it is in our busy lives. You're talking about getting up at the crack of dawn. So you have to find that time. And your husband has to take care of the kids while you go do that. So it is trying to prioritize the health strategies. And it's the number one impediment to prevention. I have patients who live in different parts of town here, and they don't feel safe walking. They don't have sidewalks to walk on. And I tell them it's 72 degrees and it's never raining in the mall.
Yeah, that's
and
true.
So, but then some of them have transportation issues. So there are something simple to recommend. It's amazing how there can be barriers to things like that even.
Yeah. Okay, so we asked some of our viewers some questions to find out if they could get some answers maybe from the experts on some of these things that they are concerned with. So we asked, one person sent us a question on our Facebook group that said, how serious is significant blockage to the abdominal aorta? And of course, we want to recommend you get advice from your doctor first. But is that a serious concern that people need to be worried about if they have that kind of issue?
Absolutely. The aorta is the major blood vessel in your body. It leaves, as the heart pumps blood, it pumps blood into the aorta. The aorta then branches into all the blood vessels that supply blood to your body. And so the abdominal aorta sometimes is a place where you don't know you have an abdominal aorta until you do.
Right, until you have issues.
Until you have issues. And if you have a blockage in your abdominal aorta, that will then affect blood flow in your legs. And so you might have pain in your hips when you walk that you think is arthritis. So you could,
wow.
And so most of what we do in cardiology is symptom driven. And so much of the disease as it lays latent is not obvious. And so it's with exertion that we bring out heart symptoms or leg symptoms for, this would be another way to say that this patient has peripheral arterial disease, meaning blockage of a blood vessel outside of the heart. And so the other inference would be this patient's at high risk for a heart event because they have evidence of vascular disease somewhere else other than the heart, but the leading cause of death for this patient would be an unexpected heart attack or stroke.
So is that common to have blockage in parts outside of the heart?
If you have a lot of the right risk factors for heart disease, we find manifestations of plaque or blockage, say in the carotid arteries, very easy to image those with ultrasound. Okay. So we find evidence of vascular disease there. And sometimes the aorta, this stuff can be found incidentally looking for other things, or it may have been done intentionally based on symptoms that the patient had. And so, but again, the biggest message would be that you have vascular disease, you're at increased risk, and you really need to be thinking about prevention Smoking is a big cause for, abdominal atherosclerosis or plaque.
So if you have blockage, can you reverse it, or do you have to have surgery and medicines to
So,
take care of it?
my patients, when we're in the cath lab, they all want liquid Drano. They want their blockage gone. I politely say to them, it's yours to keep once you get it. So prevention is what we want to do. Some of the medical therapies do reverse plaque, but at least at this point where we are, that's pretty modest.
Okay, so you need some kind of medication or a surgery for the most part.
For the most part, and prevention.
That's the key words for today, right,
It
Doc?
is.
All right, Melanie wants to know, what can I do to prevent my heart problems from getting worse? Prevention.
Yeah, well, and so if you already have heart problems, how do you prevent things from progressing? Adherence to the advice of your healthcare provider, and that's exercise, taking your medications, and we have goals for many of the things that we're trying to accomplish, and so it's truly a partnership. Because without the patient involved, we're trying to be good stewards, and we have the same goals they do. They don't want to have an event. Nobody wants a stroke. Nobody wants a heart attack. And so we're working, we're in a relationship with our patients.
Yeah. Okay, Danielle asks, is there an age requirement for coronary calcium scans?
Coronary artery calcium scans is, I think, a tremendously helpful test in the arena of primary prevention.
Okay.
So if you have established heart disease, heart attack, stroke, then it's not necessarily the best test for you. So the American College of Cardiology and the American Heart Association have added calcium artery scanning. So what does this test tell us? It tries to tell us what we can't see. So you look like a healthy woman, and you exercise, but you've got family history. And so your family history drives some of your behavior. So if we did a calcium scan for you, it would tell us, I don't know how old you are, but it would tell us up until time now how much plaque you have laid down in your heart.
Oh, wow.
Plaque that's chronic tends to calcify and emits a signal that we can quantitate. And so really, in my practice, if you're a man 40 to 60, a woman 50 to 70, I recommend calcium scanning for prevention and to have a discussion about risk.
How many times a year do we do that? Once?
Well, it's actually recommended not to have serial calcium scores.
Okay.
I will say that probably over time, 5 to 10 year intervals, because of course this isn't going to change day to day, month to month. This is again, that incubation.
Right.
And so young people should not have high calcium scores. There's just a report I read within the last 2 weeks talking about there may be value in scanning people even in their 30s. And so, so this is a surrogate for plaque or blockage. So this is what we struggle with in our offices. You pass the eyeball test, normal body weight, you exercise, you're engaged in healthcare, but are you at more risk than you really are?
Yeah.
Do objects really appear as they are?
But it wouldn't be a bad thing, though, to have this as a precaution.
No. And so that's why it's now recommended in the American College of Cardiology and American Heart Association guidelines as a, quote, risk enhancer, because when we look at the traditional risk factors, sometimes everyone passes all that. And then you have a calcium score and you're like, oh wow, I didn't see that coming. And then with your healthcare provider, you're then left with, okay, you've got the patient's attention a little bit. You told them they have heart disease, and all of a sudden their health behaviors change.
Yeah.
All of a sudden they're walking. All of a sudden they're going to their doctor. They understand.
Eating that broccoli.
They understand. Well, I'm a vegetarian, and so I will tell you, yes. Then all of a sudden, when you tell them you need a statin drug, which nobody wants to take, all of a sudden they're on board with their medicines.
Yeah. So, what does this scan pertain? How does they put liquid in your?
No, this is no IVs, low radiation, takes 10 seconds, takes, I don't know, less than 30 seconds to get scanned.
Okay.
The radiologist gives us a report to look at. It actually tells us which branches of the arteries have plaque. It does not tell us how narrowed an artery is. This is prevention. These are asymptomatic patients
Okay.
looking to further tell us what their risk is. And so it's a primary preventive, again, risk enhancer, because you pass all these, but I had a heart attack. I didn't see that coming. I was low risk. And the reality is that 50% of people that have heart attacks or strokes at the time that they had their event were considered low risk. So we are terribly interested in catching these people before they have their events. That's what people want. And so, but they also have to, this helps us tell them they have this disease that we know as cardiologists everybody has.
Yeah. This is interesting. I'd never really heard of these calcium scans before, the coronary calcium scans. So that's very, very interesting information. One more question. Sharon wants to know, how do you know if your heart is not in good condition?
The great thing about cardiology is that it's a symptom-driven business.
Okay.
Symptoms, symptoms, symptoms. And so, and the symptoms may be subtle. It might be shortness of breath. Maybe it's chest pain, or maybe it's funny pain between your shoulder blades when you exert yourself. So I think it's the marriage of this, am I at risk? And I would say that all adults are at risk. This disease doesn't discriminate. It doesn't discriminate between race, body size, whatever. Everyone's at risk. But this is the marriage between, am I at risk and am I having symptoms? Because if you're having symptoms, whatever that might be, then you ought to have a conversation with a healthcare provider. And whether it leads to a referral to a cardiologist, it might. But again, even coming to see a cardiologist, it's symptoms lead to whatever tests, and then conversations about prevention.
Well, Dr. Davis, we want to thank you so much for coming today, giving us some incredible information. And this is great. We do want to remind everyone as well to remember to go Red for Women. Go get yourself checked, both men and women in this case as well, because we're all susceptible to heart disease. And we want to thank you very much for giving us a better understanding on what we can expect as far as our health. Exercise, right?
Exercise, 150 minutes a week.
150 minutes a week. That's 30 minutes for five times a week. So throw in a couple extra minutes just for good, good.
Can't overdose.
Right? No, you certainly can't. Thank you so much. Appreciate it.